In this section, we are going to specially deal with the basics of the hemolytic anemias. Especially, I'm going to deal with the classification and what are the differences between the intravascular and extravascular hemolysis. But many times, hemolytic anemias are actually equated to normocytic anemias. I mean, typically they does produce normocytic anemias, normocytosis in the peripherals, means you don't have microcytosis or macrocytosis most of the times. So if you ask what are the cause of normocytic anemias, first thing always tell it is a hemolytic anemia. Second thing you're going to tell that the patient is, second thing you're going to tell is patient might have a non-hemolytic anemia like, for example, neoplastic anemia. Third, you can tell a lot of patients with early stages of iron deficiency anemia and anemia of chronic disease can produce a normocytic picture. Patients who are having acute blood loss can also have a normocytic picture. These are the four important things that you have to note whenever you think about a normocytic anemia, which I have discussed already in the basics of the red blood cells long time back, basics of the anemias. In this condition, if you ask me about the hemolytic anemias, the characteristic feature of the hemolytic anemias is that the reticulocyte index may be more than 2 most of the time, which means the reticulocyte production index or reticulocyte index tends to be more than 2, which means there will be peripheral blood reticulocytosis. Very important point regarding hemolytic anemia, and majority of the patients with hemolytic anemia will have a elevated lactate dehydrogenase enzyme. So these are some of the universal findings in a hemolytic anemia, but very rarely the reticulocyte index can be less than 2, especially in certain, not all, certain PNH variants. In certain PNH variants, PNH itself has a lot of variant which we'll discuss in some time, but certain PNH variants alone can have a reticulocyte index of less than 2, especially if the PNH is associated with aplastic anemia, because there is a lot of overlap between PNH and aplastic anemia. In those conditions, you might have a reticulocyte index of less than 2. But in general, this is the norm in exam, that is your reticulocyte count more than 2 and elevated LDH are the norms for any hemolytic anemia for that matters. Typically, if you ask me, early stages of iron deficiency anemia of chronic disease might show a hemolytic picture, might show a normocytic picture, but definitely at one point of time, at least in exams, you should tell that these are definitely microcytic hypochromic anemias. And definitely in this condition, the reticulocyte index will be less than 2 because of the underproduction. Because it's these are examples of hypoproliferative anemias. Similarly, in aplastic anemia, even though there is a normocytic normochromic picture, majority of the times patient will be having associated pancytopenia. At the same time, they need not be only normocytic normochromic, but they can be macrocytic anemias also, very important. So aplastic anemia can result in a macrocytosis as well, where again here the reticulocyte index will be less than 2, definitely not more than 2. Similarly, in acute blood loss, easily you can diagnose by history. History itself will tell you acute blood loss. A lot of the patients will have definitely a bleeding history. At the same time, the patient will have a reticulocyte index of more than 2. In acute blood loss, you will have a normal LDH only. That will definitely differentiate you from a hemolytic anemia. And a lot of other differences are also there, which we'll discuss later on. Bilirubin will be elevated in hemolytic anemias, whereas bilirubin may be normal in a acute blood loss. But acute blood loss typically diagnosed with the help of history itself, history of surgery, trauma, massive bleeding, hemoptysis, hematemesis, hematuria, melena. A lot of things are there. So you can diagnose based on the history itself a lot of times. So these are the characteristic examples of normocytic anemias. The most important normocytic anemia is hemolytic anemia, and that's what we're going to discuss in this particular picture. This is an introductory video on hemolytic anemias. So what are the things you have to know in the introduction? The first thing is the classification. So the classification of hemolytic anemias. So how you can classify in hemolytic anemia is based on two things. So I can put a small table sort of thing. So what happens typically is, first you have to see the location of where it is happening, and you can see the mechanism of anemia. And third thing, you can see certain etiologies, important etiologies of hemolytic anemias. So first let us see intrinsic location. This type of intrinsic hemolytic anemias are also referred to as something called corpuscular hemolytic anemias. These are also referred to as corpuscular defects or corpuscular hemolytic anemias, intrinsic defects, which means the defect is within the RBC, not outside the RBC causing hemolysis. Some problem within the RBC is causing some hemolysis. Because of that, you are getting a hemolysis. Mechanisms, it could be first one due to an enzyme deficiency. I can write in a different color, so probably it could be an enzyme deficiency. Best example for enzyme deficiency could be a G6PD deficiency, or it could be a pyruvate kinase deficiency, which you're going to see in the later part of the lecture. And here something called a PFK deficiency, that's called a phosphofructokinase deficiency. And second thing, you might also get in certain membrane abnormalities. The examples of membrane abnormalities causing hemolysis, classic example, hereditary spherocytosis. You can also tell hereditary elliptocytosis also, but typical gold standard example is hereditary spherocytosis. And third thing, you might even get in a hemoglobinopathy, which we have been discussing for quite a long time. Hemoglobinopathy. So best examples for hemoglobinopathies causing this hemolysis is, you can get in sickle cell disease, and even you can get in a thalassemia. Sickle cell disease, and you can get in a thalassemia. And another example for membrane abnormality I have not written here is because you might even get in a Spursel anemia. You have something called a Spursel anemia or a PNH. Even in a PNH, for example, if you want to know membrane abnormality, other membrane abnormalities, you can even write a paroxysmal nocturnal hemoglobinuria and a liver disease causing Spursel anemia. So why I have written that thing only in black separately? Because only what I have written in black here, this PNH and liver disease causing Spursel anemia, echinocyte Spursel anemia, tends to be acquired. Remaining all those things tend to be inherited. For example, your enzyme deficiencies tend to be inherited. For example, let me shade in yellow. The enzyme deficiencies tend to be inherited. Your membrane abnormalities, only hereditary spherocytosis and elliptocytosis tend to be inherited, and your hemoglobinopathies tend to be inherited. So all this tends to be inherited. Only your acquired membrane abnormalities due to PNH or liver cell disease causing Spursel anemia are tend to be acquired. So that's why I written separately. So in this, everything tends to be inherited, only that PNH and liver disease causing Spursel anemia tends to be acquired. Remaining, this is how you can divide. Intrinsic corpuscular defects can divide enzyme deficiencies, membrane defects, and your hemoglobinopathies. Next thing what you can write is extrinsic defects. Extrinsic defects are also referred to as something called extracorpuscular defects. Extracorpuscular defects can be divided into, again, number one, traumatic, or you can write simply immune mediated, then you can go for traumatic. So one is immune mediated. The moment you tell about immune mediated, which means there are only two things are there. One is called autoimmune hemolytic anemia, or it should be caused by certain drugs. Drugs also cause a picture similar to that of autoimmune hemolytic anemia only, but typically you can write separately autoimmune hemolytic anemia and drugs, which is there is a separate section on that. Then you might get with a traumatic hemolytic anemia, where the RBC is passing through a rigid area, or through a meshwork of thrombus, might get teared, and it can be completely squeezed, and it can be sheared into pieces. Because of that, you might result in a hemolytic anemia. So two examples, one is microangiopathic hemolytic anemia called MAHA, or it could be a macroangiopathic hemolytic anemia due to prosthetic valves, dialysis circuit, or even a left ventricular assist device. So microangiopathic versus macroangiopathic. So these are some of the examples. Then you have something called direct infection and toxins. If you ask me about best example, I can tell malaria, I can tell babesiosis, babesia, then certain venoms of snakes and spiders. Wilson disease also can cause due to due to excessive free copper may result in hemolysis. Total copper may be reduced in serum, but free copper will be increased because of poor ceruloplasmin binding. So because of that free copper, it might result in hemolysis, because Wilson disease is a very important thing, because many people do forget the presence of hemolysis in Wilson disease. So Wilson disease may cause this, or if you are giving a hypotonic saline, long-term hypotonic infusions, any hypotonic infusions may result in hemolysis, because hypotonicity causes red cells to break by osmotic fragility. So definitely all these are some of the important causes. Finally, last one, you can put something called an entrapment. You can put something called entrapment. Entrapment typically happens in hypersplenism, where because of the RBCs are trapped in excess by the enlarging spleen, that might be subjected to more contact with the reticuloendothelial system, splenic macrophages, which might digest more and more RBCs. So this is the reason why you're going to get hemolysis in a hypersplenism also. The beauty of extracorpuscular defects, extrinsic, is that all are acquired. Every single damn thing which I have mentioned in this extracorpuscular defects is acquired in nature. They are not inherited at all. So these are the typical examples. This is how you classify a hemolytic anemia in the first place. Once you have known about the classification, the next thing what you have to know is the difference between an intravascular and a extravascular hemolysis. What do you mean by intravascular hemolysis? What do you mean by an extravascular hemolysis? Intravascular hemolysis typically, happens within the vessels, in the intravascular compartments. Extravascular hemolysis typically happens in the spleen and the reticuloendothelial system, which means here the main reason for the hemolysis is the macrophages digesting the RBC. It's not the RBC tearing up within the vessels, it's the macrophages ripping apart the RBC after swallowing them. So this is what we refer to as something called extravascular hemolysis. So in this condition, what will happen is, so to understand things better, I can show an image here. So what's happening in extravascular hemolysis, you can see here the excessive RBCs are actually swallowed by the macrophages by erythrophagocytosis, and because of that they are ripping apart the RBC into globin, iron and protoporphyrin. This iron will be either stored or released, and this globin will be recycled by digesting amino acids, and which will be recycled again. But this protoporphyrin will be converted to bilirubin, I told you, by two enzymes. One is heme oxygenase and second one is something called a bilirubin reductase. So these are the enzymes, biliverdin reductase, because first the heme will be converted to biliverdin, then biliverdin will be converted to bilirubin. So by biliverdin reductase and heme oxygenase, you are going to finally form a bilirubin. Bilirubin will be coming in the blood as unconjugated bilirubin, which will be entering the liver, where there will be something called a bilirubin handling, which is a completely different and separate thing which I have discussed in hepatology. And in the liver it will be converted to bilirubin glucuronides, which will be excreted in the stools, as well as it undergoes something called a enterohepatic circulation, where this enterohepatic circulation will take some of the bilirubin and excrete in the kidney as urobilinogen. So this is what is going to happen. So in general, if you ask me, increase in unconjugated bilirubin will be too much in an extravascular hemolysis. That is because they produce bilirubin more. That's it. So they don't release free hemoglobin. So free hemoglobin levels will be normal in case of a extravascular hemolysis. But whereas if you take an intravascular hemolysis, what typically happens in intravascular hemolysis is that the RBC get shared up within the vessel, inside the vessels, within the intravascular compartment. Your RBC breaks down. Once your RBC breaks down, undergoes lysis, they release all the content inside the RBCs. The most important, the RBC content is going to be hemoglobin. Please do remember here, the hemoglobin is not ripped apart inside the macrophage. It's released into the intravascular compartment itself. This free hemoglobin is quite dangerous, because to trap this free hemoglobin, there is one molecule, specialized molecule, that is designed to trap this free hemoglobin. That is called haptoglobin in the serum. So if you ask me what happens to haptoglobin, because of the saturation of the haptoglobin with hemoglobin, because a lot of hemoglobin is now released because of intravascular hemolysis, the serum haptoglobin levels tend to decrease in these patients. At the same time, this free hemoglobin can be filtered by the your kidneys, and you might result in a hemoglobinuria or even a hemosideruria if the hemoglobinuria happens for a long run. So you might result in the free hemoglobin leaking into the urine. So that is very important. And again, some of the hemoglobin may get transformed to something called a methymalbumin. So this is also possible. So all these levels, methymalbumin levels will be increased, hemoglobin and free hemoglobin and hemosiderin levels in the urine may be increased, and serum haptoglobin levels may be decreased. So whereas in this condition, since the free hemoglobin levels are normal in extravascular hemolysis, your haptoglobin level tends to be typically normal. So whether they can produce jaundice or not, intravascular hemolysis, can they produce jaundice? Actually yes, theoretically yes, but practically no. Very little jaundice may be there. Why jaundice is very little? Because, and why it happens in the first place, because this hemoglobin itself can be trapped by your RES. RES can trap hemoglobin, free hemoglobin also. We have lot of receptors. We have discussed in detail about all this principle in the iron metabolism. So definitely your reticuloendothelial system itself can trap a lot of free hemoglobin. And this free hemoglobin, some of the free hemoglobin that is trapped may be converted to heme and globin. And this heme and globin is again will be ripped apart into iron and protoporphyrin, iron and biliverdin, with the help of some enzyme called heme oxygenase. This biliverdin will be further converted to bilirubin by an enzyme called biliverdin reductase. So which means you can get a little bilirubin due to this hemoglobin trapping by reticuloendothelial system, which is still absolutely possible. So but the increase in the bilirubin in intravascular hemolysis will be much lesser compared to the increase in the bilirubin in extravascular hemolysis. So extravascular hemolysis, all the RBCs, all the hemoglobin is ripped apart within the reticuloendothelial system. So the bilirubin production will be too much in extravascular hemolysis in comparison with the intravascular hemolysis, where bilirubin production will be very less, because only some of the free hemoglobin can be trapped. This haptoglobin hemoglobin complex can be trapped by your reticuloendothelial system. So these are some of the basic differences between intravascular and extravascular hemolysis. So let us see as a table. So let us write an intravascular hemolysis here. Let us write an extravascular hemolysis here. In intravascular hemolysis, what happens is your free hemoglobin in the plasma. You can write serum free hemoglobin. Serum free hemoglobin in intravascular hemolysis will be very high, whereas in extravascular hemolysis will be completely normal. Then if you ask about the serum haptoglobin levels, definitely in intravascular it will be terribly decreased, or even it may be completely absent. There will be no serum free haptoglobin, whereas in extravascular it tends to be completely normal most of the times. Very severe case might be decreased, but it usually tends to be normal. What about the LDH? LDH increase can be seen in any hemolysis, but significant increase is seen with intravascular, but very mild increase will be seen with extravascular hemolysis. Similarly, if you ask me about the unconjugated bilirubin levels or simply the bilirubin levels, intravascular definitely will be increased and extravascular increase will be more compared to the intravascular. The reason I told you already. And you ask me urine free hemoglobin and hemosiderin. Typically, it's very high in intravascular hemolysis. Usually, it is not the feature of extravascular hemolysis. We have discussed already. And next thing where you can see in the peripheral smear. In the peripheral smear, typically you will see spherocytosis and you can see Heinz bodies. Many times you can see Heinz bodies, these bite cells, blister cells. All these things are typical examples of G6PD deficiency, which is a classic example of an intravascular hemolysis, G6PD deficiency. Where here also you can see spherocytosis, or you can see sickle cells if the patient is having a sickle cell disease, drepanocytes, which means spherocytosis is a common finding in the peripheral smear of any hemolytic anemia. It's not only a feature of hereditary spherocytosis, it's not only a feature of a particular event. It can be seen in any hemolytic anemia, intravascular as well as extravascular. And again, similarly, what are the common things? Apart from this one, common thing will be increase in the reticulocyte count. Increase in the reticulocyte count, and reticulocyte index being more than 2 is a common feature of both intravascular as well as extravascular hemolysis. And not only spherocytes, additionally presence of cystiocytes. Why this point is very important? Because cystiocytes always go towards intravascular hemolysis. Typical example of where cystiocytes you will see is in a MAHA, that's called microangiopathic hemolytic anemia, where usually in pure extravascular hemolysis you won't get cystiocytes, but spherocytes can be feature of more. If you still want to differentiate, tell one solid point: cystiocytes means intravascular, spherocytes usually go towards extravascular, but not always the case. Spherocytes can be seen in both. But typically, spherocytes means extravascular, cystiocytes means you can come towards intravascular, but not exactly, because spherocytes can be seen in both intravascular as well as extravascular in reality. But cystiocytes definitely intravascular. There's no doubt about it. Only sharing. Some characteristic examples if you want to give for intravascular and extravascular. You can see intravascular in cold autoimmune hemolytic anemia, whereas extravascular you can see in warm autoimmune hemolytic anemia. Then in microangiopathic hemolytic anemia, macroangiopathic hemolytic anemia, G6PD deficiency, paroxysmal nocturnal hemoglobin, all these things are examples of intravascular hemolysis. Whereas for extravascular hemolysis, you have something called warm antibody hemolytic anemia. After that, you have sickle cell disease, then you have hereditary spherocytosis, then you can have pyruvate kinase deficiency. In all these conditions, classical thing you will see is the extravascular hemolysis. So this is what you are going to see as a difference. And remember, both intra as well as extravascular hemolysis can also result in something called erythroid hyperplasia and bone marrow. You can have erythroid hyperplasia and bone marrow, with the exception being PNH, because if the PNH, I mean not in all PNH, if the PNH is specifically associated with aplastic anemia variant, then they might show hypocellular marrow and like erythroid hypoplasia also. But in general, erythroid hyperplasia is a common feature of all of the hemolytic anemias, including most common varieties of PNH, because hemolysis is the most important picture there. So your reticulocyte will be more, at the same time your erythroid hyperplasia in the bone marrow is a very, very common picture. At the same time, if you ask me whether DCT may be positive or not, direct Coombs test may be positive or not, it can be positive in both or it can be negative in both. Where it will be positive? If it's an autoimmune hemolytic anemia. In this condition, if it's a warm autoimmune hemolytic anemia, it's going to produce extravascular hemolysis. Similarly, here also you can get a positive direct Coombs test if it's an autoimmune hemolytic anemia. Typically, like in a warm autoimmune hemolytic anemia, you will get an extravascular hemolysis. In a cold autoimmune hemolytic anemia, you are going to get an intravascular hemolysis usually. But anyway, you can get DCT positivity in both these conditions, both intravascular as well as extravascular hemolysis, that is direct Coombs test may be positive. So I think this is a very short section. With this, we are going to move on to the next important section, that is on hereditary spherocytosis, which is going to come on the next video.